The Maori and Pacific Islander community in Australia has been identified as one of the ethnic groups significantly impacted by type 2 diabetes and its complications, and poor medication adherence has been identified as a potential factor leading to these outcomes. There is limited literature that explores how the social and cultural context of this community influences beliefs and behaviours around diabetes and medication management. My research seeks to explore how Maori and Pacific Islander people in Australia approach type 2 diabetes and its management with a focus on medications. Semi-structured interviews were conducted and Talanoa Pacific storytelling methods were used to build trust and cultural respect. The sample of participants had been prescribed medication for diabetes and were recruited from the community. Inductive thematic analysis was utilised and recruitment with participants continued until thematic saturation was achieved after the 18th interview. Of these interviews, there were 8 male and 10 female participants, the largest number of participants identifying as Fijian. There were 3 themes and 6 subthemes identified, and these were often interlinked. Cultural identity, which included collectivism, spirituality, and food, had an important role in how participants viewed and responded to diabetes and management of medications. In some circumstances, family were described as a key motivator to staying healthy. However, collectivism also resulted in many participants putting their family, the community, or the church first before their health and taking medications. Participants frequently described their health behaviours in religious or spiritual terms, and this influenced medication adherence in different ways. Some were motivated to take their medications as they described their body as a temple of the Holy Spirit, while others believed that God had ultimate control over their health, saying it's God's will and by faith you'll be healed. And these participants often relied on their spiritual faith for healing rather than medications or lifestyle changes. An abundance of food and a larger body image were described as a sign of social status and prosperity, and participants often had an affinity to traditional foods that were described to give them strength. There were also social norms around foods, and participants described an obligation to take part in cultural feasts, saying it was disrespectful not to. As a result, participants often struggled with their blood sugars, and this led to them thinking that their medications lacked efficacy and led to non-adherence. Participants described a range of health beliefs and perceptions that changed the way they approached their diabetes management. Some participants depicted diabetes as short-term and curable, saying if you eat right, you can reverse it. In these cases, medications were used sporadically, temporarily, or not at all. Participants also described shame and embarrassment around diabetes, which led to privacy, delayed treatment seeking, and a lack of support. Quite commonly, participants also believed diabetes medications to be damaging to the kidneys, and for those that expressed these concerns, they often relied on traditional or natural alternatives prior to or instead of prescription medications. Participants spoke about positive experiences with the healthcare system, emphasising the benefits of holistic support, and described this to include medications and other self-care aspects, particularly food, and consideration of their social environment. One participant also highlighted the importance of trusting her doctor on a religious level, explaining the importance of connecting culturally. Participants also described challenging experiences and spoke about how their healthcare professionals often portrayed diabetes negatively, using the fear of complications or insulin injections to promote adherence. As a result, some participants disengaged with their diabetes management. Other participants explained how communication barriers resulted in taking insulin at the wrong time, leading to disappointment about the efficacy of their medication and non-adherence. The key findings were that we first need to appreciate that culture has a big influence on how Maori and Pacific Islander people approach diabetes management, and we should also acknowledge that each person is different and an open conversation is needed to understand exactly how culture influences their decisions. Secondly, as healthcare professionals, we should know that participants may not view diabetes as chronic, manageable and preventable, but instead as a short-term curable or uncontrollable condition. And lastly, there are opportunities for us to improve the way that we engage with Maori and Pacific Islander peoples, and we should ensure that our education and interventions take into account their social and cultural context.
Thank you for the opportunity to speak about our improvement work in the fracture clinic at the Women's and Children's Hospital, Adelaide. We are a quaternary paediatric hospital for South Australia. Our 5 weekly fracture clinic sees approximately 4,200 children each year. Our key referral sources are our Paediatric Emergency Department, PED, other hospital emergency departments and GPs. Like all paediatric fracture clinics, it is busy. We started to have a conversation about the pre-ordering of x-rays. Did we do too many or too few? Were we needing to repeat x-rays due to the lack of quality or availability? And what did our flow-through clinic look like? We had 3 aims: to document the pattern of ordering follow-up x-rays for simple limb fractures, to identify the number of low-value x-rays, and to consider the impact of patient flow through the fracture clinic. We obtained ethics for our continuous improvement project. We mapped the potential patient pathways through fracture clinic from referral to discharge. Our clinicians manually collected the data, including referral source, appropriateness of referral, the need for radiology before or during the appointment, and the appropriateness of radiology. This was based on their clinical judgment. A consumer survey helped us to understand their waiting times, openness to alternative follow-up, such as their GP or a closer hospital, and preference for timing of radiology, either the same day or the day prior to their appointment if it's clinically appropriate. The key points we identified were: 1. The circular pathway. Many patients checked in, saw a doctor, went to x-ray, then back to the doctor. While some of these children needed a clinical assessment to determine the need for radiology, clinicians identified that 75% of the patients who would have been suitable to have an x-ray prior to seeing the doctor didn't get one. Secondly, 25% of appointments were considered unnecessary, either because follow-up was not required or the Women's and Children's Hospital Fracture Clinic was not the most appropriate setting for the follow-up. And thirdly, the mean waiting time was not unreasonable. Only 18% of consumers waited for longer than they expected, but there were a few that had a waiting time of over 100 minutes. Traditionally, to avoid delay in booking appointments, the majority of referrals for the fracture clinic were actioned by senior nursing staff without routine orthopaedic clinician input or triage. Our first change was for the orthopaedic medical staff to review all referrals. In this process, families were often contacted by medical staff to provide reassurance by telephone, organise repeat x-rays in the community, or suggest alternative follow-up arrangements. While our data check did show some improvement, the process was overly burdensome and not sustainable. Our next change stepped further back, and we asked the PED staff to contact the orthopaedic team before making a fracture clinic referral, and we revised our referral form to reflect this change. It is worth noting here that at this time, the Women's and Children's Hospital had started to implement the COVID-19 management strategies, including reducing attendance at the Women's and Children's Hospital where possible and minimising elective surgery. This process allowed early definitive care by the orthopaedic team, preferencing video or telephone follow-up and, where appropriate, referral back to an alternative health care provider. This model provided the best care for patients and families' point of view. However, it was difficult to maintain once COVID restrictions eased, activity increased, including elective surgery, face-to-face clinics and PD presentations. The orthopaedic team have insufficient staffing to provide definitive timely care for all patients presenting to PED. The consumer survey was not repeated due to the COVID management strategies. The first key improvement identified was for the patient group that required an x-ray on arrival. Pre-intervention, 14% of this group had their x-ray before seeing the doctor. This was improved to 50% following the triaging of referrals by the orthopaedic medical staff, and it was 100% when all ED referrals were discussed with the orthopaedic team. Secondly, unnecessary x-rays on arrival went from 7% to 0. The third key improvement was that our unnecessary appointment rate reduced from 25% to 0. The effect on staff and patient family satisfaction within our clinic was remarkable. Our clerical staff reported that the fracture clinic had gone from their worst to their favourite. There was also a positive effect on the other orthopaedic clinics which previously had to accept fracture clinic overbookings. We were able to reduce hospital attendance, which in turn minimised family disruptions, school absence and time off work for parents and caregivers. as well as the practicalities of attending, such as travelling and parking. During the COVID pandemic, with social distancing requirements, this was even more important. While we were pleased with our results, as with any improvement activity, the key question is, can it be sustained? As we mentioned, the timing of the project was fortuitous that it coincided with the COVID management plan, implementing early definitive care and increasing telehealth appointments. However, during the height of the pandemic response, there was also a decline in PED activity with a corresponding reduction in waiting times. Anecdotally, the orthopaedic team are now consulting later in the evening or overnight for children with simple fractures in the paediatric emergency department. This impacts on staff wellbeing and the workflow for the following day, as the orthopaedic medical staff are on site during the day and on call overnight. They are not shift workers. Fracture clinic referral numbers have increased post-COVID compared to the pre-COVID levels, and there is a feeling that we are not sustaining our success. We hypothesise that many children with fractures present to PED relatively early in the day, but now that PED is busy, children with low priority triage categories, like simple fractures, are waiting longer and being seen later. Our next steps are to review the PED presentations and discharge times for children with simple fractures for the period of time that the audits were conducted, and to determine whether there is scope to develop PED avoidance strategies and strategies to achieve early assessment and discharge for simple fractures. Thank you.
Good afternoon, everyone. I'm Shangeetha, a paediatric dentist at the Women's and Children's Hospital. I'd like to start by thanking Choosing Wisely Australia for the opportunity to present on this platform today. I will be sharing with you our findings from a recent audit that we conducted in the dental department, looking at the value of blood cultures in the management of children with dental abscesses and facial cellulitis. So facial cellulitis secondary to dental abscesses account for approximately 25% of emergency dental admissions at the Women's and Children's Hospital. In the absence of documented South Australian guidelines for the management of such cases, the historical treatment has included obtaining blood cultures, an abscess swab, commencing antibiotics, and treating the offending tooth either via root canal treatment or extraction. Whilst the international literature on this topic is scarce, existing guidelines from several leading paediatric centres have indicated that there is no need for blood cultures in the absence of signs of sepsis. So the aim of our study was to determine the value of blood cultures in the management of facial cellulitis secondary to dental abscesses in children aged 2 to 18 years who presented to the Women's and Children's Hospital. Cases were identified using the ICD-10 codes and were included if the child was aged between 2 to 18 years, presented by the Paediatric Emergency Department, and did not meet the sepsis pathway criteria. A retrospective medical record review of all eligible cases over a 36-month period was conducted, wherein we looked at what treatment was provided, what investigations were performed, and whether these investigations had any impact or influence on the treatment provided. So in total, 86 medical records were identified and reviewed. 9 cases were excluded because they had facial cellulitis but of non-dental origin. None of the excluded cases met the criteria for sepsis pathway. Of the 77 cases, 49% had a blood culture taken, which had no impact on treatment provided. A point worth noting is that in all cases, the blood culture results were only available after treatment was provided, and in most cases, after the patient had been discharged. And of those that had blood cultures, all of them had at least one other blood test done, again with no evidence of any influence on treatment provided. In all these cases, investigations were initiated either by the PED staff or the dental team. But it is worth noting the graph on the top right here, which shows that over the 3-year period, the percentage of blood cultures being taken had decreased, although there's still variation in practice. So to summarize, our findings revealed that in the absence of sepsis, there is very limited value in collecting blood cultures in children with facial cellulitis secondary to dental abscesses. These findings support what's known in the literature. Blood cultures are not taken in isolation. Often other tests are done as well. So we really have the potential to reduce unnecessary blood cultures and tests being done in approximately half of these children who present to the emergency department. So what does this mean for us as clinicians? Moving forward, we hope to apply the improvement methodology to understand and assess why we take blood cultures and how can we reduce the number of unnecessary blood cultures being taken. There is definitely a need for education and awareness among staff on the indications of taking blood cultures, and perhaps developing local management guidelines to facilitate this process. So the next phase of this project will hopefully involve implementation of these changes and reviewing to see if these proposed changes help improve the outcome. Thank you.
The Consumers Health Forum of Australia was engaged by NPS MedicineWise to carry out consumer health literacy segmentation research to find out more about the attitudes and perceptions of grassroots consumers in relation to the quality use of medicines. About 1,500 people were surveyed, kitchen table discussions were held, desktop research and data analysis were employed. We already know that the people at higher risk are those with multiple conditions, people who are taking lots of medicines, and those with English as a second language. The segmentation research found that there is a segment of the population labelled the quick fix that includes people who take 1 or 2 medicines every day, are happy to take whatever their doctor recommends, have higher healthcare service use than the other 2 segments found in the research, and they don't ask a lot of questions about their medication. One thing the participants emphasised was the importance of clear and easy to understand information that is targeted to those with low health literacy and is available in different languages. The research also found that we need to embed health literacy into systems. This includes the integration of health literacy into education for consumers and healthcare providers. One way we can respond to these findings might be to give consumers and pharmacists the means to start a conversation in the same way that choosing wisely's 5 questions challenges the people to start a conversation with their doctor. We need consumers to feel comfortable asking questions. With this in mind, CHF's Safety and Quality Special Interest Group, a group of 25 health consumers, were consulted. They were keen to explore the idea, and they came up with 5 key areas that could be developed into 5 questions to ask your pharmacist. Those 5 key areas were the following. Question 1 is about the basics. How much will my medication cost, and is there a generic option that is cheaper? What is the difference between the generic and brand names of this medicine? And this question may also include asking, what is the name of the medication? Question 2 is about the side effects and other related advice. Are there major common side effects or special instructions? This question may also include asking if there are side effects that are dangerous and whether or not other medications, food or drinks should be avoided. Can I drink alcohol, for example? The theme for question 3 is about managing a daily routine. If I am taking 2 or more medications or over-the-counter supplements, does my pharmacist or GP need to do a regular review to maximise their effectiveness? Related questions include, does the pharmacist need to know about my other medications? What options and tips can help me organise my medication? For example, Webster packs, pill boxes, medication reminders, storing regular medication in one place, and maintaining a routine. Should I keep an up-to-date list of all my medications on me? If so, how do I do that easily? Question 4 was about making mistakes. What if I miss a dose or take a dose incorrectly? And question 5, how should I store my medication? Is it important to keep it in the fridge, for example? Obviously, these themes and questions are just a starting point. We need more consumer feedback to guide the refinement of these 5 questions. We will need pharmacist feedback to find out more about the most frequently asked questions they get in their daily interactions with consumers. Some key points that may need to be considered in refining the themes and questions include that wording needs to be refined to be as inclusive as possible. The questions need to be applicable to those taking medication for their mental health as well as their physical health. The transparency of costs needs to be considered. When it comes to medicine reviews, who is entitled to what kind of medicine review under Medicare or otherwise, and what constitutes a medicine review? Are these medicines and the way they're worded reaching older and younger Australians who may find these conversations difficult? Are the questions easily translatable for use, for example, in areas with specific cultural or linguistic demographics? How do we disseminate these 5 questions, and how do we target the right people? What methods do we use? 5 questions to ask your pharmacist would share the responsibility of improving consumers' understanding of medicines literacy in line with the central principles of the National Medicines Policy. It could also help improve health literacy by progressing some of the key findings of CHF's consumer health literacy segmentation research, and it would contribute to choosing wisely's worldwide coordinated approach. This is just the start of the conversation. Let's continue this discussion. Thank you.
Hello, my name's Sarah Ashover, and today I'd like to tell you about a statewide project in Queensland emergency departments known as PROVED, or Promoting Value-Based Care in Emergency Departments. And how we're trying to go about that is finding pockets of innovation that have been done in isolation in the silos that are created by the division into hospitals and health services, develop and fine-tune the resources so that they can be lifted up to statewide level and then disseminate them across the state. So we started back in 2019 trying to find the pockets of innovation, and we put out a statewide call for written applications that had to be scalable, relevant, practical, and most importantly with demonstrated outcomes measured at the pilot sites, but also had to be measurable at statewide level. And the shortlisted applications were invited to present at our Shark Tank-like event known as Pitch Fest. And they were judged by a multidisciplinary panel with consumer input. And there were 6 initiatives selected in that first round. From there, we set about trying to develop the resources, and we did a lot of statewide consultation and made sure that we engaged as many stakeholders as we could. We developed the resources, made them look a bit more slick, and made sure to always credit the individuals and the departments where the initiatives were developed. And then to disseminate. So our strategies, as I mentioned, we wanted to make sure that things looked pretty slick, and this is unearthed some unknown talents in our team. These are the first 6 initiatives. We developed icons for each, and also the front and back of a postcard that we used to promote it. We have what we think is fairly sound methodology. We target clinicians while ensuring to engage executive. We conducted innovation showcases where we take our resources and actually present to frontline staff, ED leadership and executives that are interested. And the initiatives are presented very much on an opt-in basis. We tried to make things as customizable as possible, and local sites could select those initiatives that were relevant to their needs. One of the critical things we've done is had some funding to co-fund some offline time, usually for nursing staff, for local project champions to help facilitate implementation of the initiatives selected. And for a key communication strategy, we've tried to move away from posters and emails, and we've installed digital screens in around 20 emergency departments that are participating across the state in clinical areas to promote the initiatives and to feed back the local results. A really important thing that we've done is made sure that there's a sustainability plan, place in plan for each of the initiatives, and that includes ongoing custodianship of the resources beyond the life of the project. So what have we achieved? So far we have had 2 rounds of selection, identified 10 initiatives from 7 different departments. We've engaged 22 EDs to implement. Our outcome highlights include 1.3 million and 615 days estimated savings from the first 9 of 18 sites from the cannulation reduction initiative that came out of the Royal Brisbane based on some work done in Victoria. The standardised intubation package was included in the REST guidelines for 2020 and rolled out to over 140 rural and remote facilities in Queensland just in time for COVID last year. And that came out of Gladstone. And the Text Cultural Safety Initiative from Cairns has led to the establishment of a statewide group to sit under the ED network, and they'll continue to champion for improvements to cultural safety in emergency departments for First Nations peoples. There's also subtle changes which are harder to measure. We've heard that there's permanent quality improvement appointments in EDs, that application to PROVED has been integrated into local processes, and that rotating staff are familiar with the initiatives, having encountered them elsewhere. But the thing that excites me probably the most is the chatter. So we're just starting to, really be spoken about at a statewide level, and we have regular inquiries to PROVED about when the next Pitch Fest event will be. So for those of you in the ED space in Queensland, it's the 4th of August at this stage. I'd like to just show you some of the graphics that we've been displaying on the digital screen. So as well as the PROVED initiatives, we've been partnering with Choosing Wisely and ASIM to promote the ASIM Choosing Wisely recommendations. We also have wellness messages. We've tried to introduce a little bit of humour and be a bit quirky and create conversations. More information on the particular initiatives is available on the Queensland Health Improvement Exchange, but if you Google "proved" with a hyphen, that will come up. And please contact us if you would like any more information. Thank you very much.